is panel number 2, Understanding the Issues, and we're going to go for about an hour. So, how does the lack of affordable housing impact the health and well-being of individuals and our community as a whole? From outreach to the homeless to market auctions, what is the spectrum of housing needs in our community? It's important to build a shared understanding of the pressing issues and a common language as a first step to building housing solutions together. Our moderator for this morning's panel is Tony Law, wave Tony, who was chair of the Islands Trust Community Housing Task Force, past president of Islanders Secure Land Association, which is a community land trust that owns 20 acres to develop as community housing, and who organized a conference on housing solutions for small communities. He is an Islands trustee for Hornby Island and previously served on the Comox Valley Standing Committee on Housing and Homelessness, and he also, in his spare time, hosts a program on local Hornby Island radio. And now to introduce our panelists. Dr. Charmaine Enns, if you could raise your hands, everyone knows, that's great, is originally from Saskatchewan and was initially trained as a family physician. She subsequently qualified as a specialist in preventive medicine and population health with the Royal College of Physicians and Surgeons of Canada, and has been the medical health officer for the North Island for the past 10 years. Roger Butcher is BC Housing's Regional Director for Vancouver Island. He has been with BC Housing for over 26 years in a variety of capacities before becoming the Lower Mainland's Regional Director in 2002. From Richmond to Pemberton, he worked with the nonprofit housing sector, overseeing a staff of over 100 and over 2,800 housing units. Wow. Since 2005, he has supported nonprofits in providing housing throughout Vancouver Island and the Gulf Islands. Roger and his team work closely with BC Housing's Development Service Group to assist nonprofits to develop new housing opportunities on the island. Brad Crewson is the Streets to Homes Coordinator for Pacifica Housing Advisory Association in the Capital Region. He has over 15 years of experience in the social services and counseling fields, and has spent the last 7 years managing supported housing and coordinating support programs for homeless individuals in Victoria. Previously, he has worked on a variety of projects for people managing mental health and substance use concerns, including skills development, employment counseling, and youth work. Brad is also very involved with restorative justice in Oak Bay. Major Kathie Chiu is currently the Executive Director of the Victoria Alcohol Rehabilitation Centre. Kathie has been working with the homeless and addicted for 22 years with the Salvation Army. During her 14 years in Maple Ridge, she was instrumental in raising funds and building the very first emergency shelter and transitional housing service, which opened in April 2003. She was a member of the Regional Steering Committee for Homelessness in Vancouver, a member of the Social Planning Advisory Committee to Maple Ridge's Council, co-founder of the Alouette Home Start Society, and was an active member of the Community Network in Maple Ridge. She has a large family of 5 children. The 2 youngest are still at home, and she has 8 grandchildren. So the panel is going to start here. Just a reminder, there are index cards and pens on your chairs. We ask that you write down your top takeaway message at the end of the panel discussion and place it in the box on the table by the door, because your feedback is really valuable. Thank you.
Thanks so much, Anne. It's really an honor to be here. I'm excited that this event is happening. On one level, housing is very simple. It's a roof over everybody's heads. But for any of us that's been involved, we know creating housing is very complex. It involves a partnership of people, organizations, and government. And for effective partnerships, we need to have a common understanding of the issues. And we're really lucky, as you've heard from Ann's introduction, that we've got a panel of people with a lot of knowledge and experience to share. I think what's also important in working together is knowing a little bit about each other as individuals. So just, we're going to have a little quick round. You've heard all these wonderful things about our panelists, but I'd like to give them each an opportunity to say a little bit about, what you do, what's motivated you to get involved in housing, and what inspires you to continue being involved in this field. So, Charmaine.
So thanks, Tony. My name is Charmaine Enns. I'm the public health doctor for the North Island. That's what I do. I work for Island Health. But in terms of what motivates me, actually, if I could just take it back to a story of about 20 years ago when I was a very young family doctor and we moved to Kenya, East Africa. And because I was a woman and I have ovaries, I said, they put me in charge of obstetrics and pediatrics. So this was a 220-bed hospital in rural Africa as a mission hospital. People would come from literally all over the country to receive care because they knew they would get excellent care. But that meant they maybe walked a week in labor. So what happened for me in that year is I was a part of people's lives where they would go to extraordinary lengths to come for the excellent care. For example, there was one situation where a woman came in and we miraculously, the baby was in serious distress and actually went flat and died, but we brought the baby back and we were able to save this baby's life, which was quite a wonderful experience. However, 3 months later, that baby was back in the pediatric ward and died from something that was quite preventable. It was heartbreaking for me because I was the one that intervened to save that baby's life in the first place and then had it die in my arms 3 months later. And those experiences happened over and over. And the realization that, and we started outreach clinics and we started to do things to get out into the community more. But really the issue is no matter how good the care is at that point at the end, i.e. the hospital, everything that happens out there determines what happens in here. So that's where my thinking changed and my heart's desire changed to actually be a part of population health, to get out in front of all of that stuff that determine what happens in the site. Hospitals can come and go. They are a point in time in people's lives, but it's what happens in the community at a population level that really is, I thought, and still believe, is ultimately going to make the difference, and that's where housing comes in as well.
Brad Crewson with Streets to Homes, Pacifica Housing. What was initially, I think, the inspiration for me to get involved in this field remains what continues to motivate me. And that is that I did a lot of work when I first started doing social work with people, helping them work on employment plans and to get back into the job market, working with people who were managing addiction issues to do relapse plans and help manage or deal with their substance use issues. Those kinds of efforts, I never felt really actually came to fruition if the person wasn't housed. If they don't have a home, a place they can call home, if they don't have a place where they're safe, if they don't have a door to close at the end of the day and say, this is where I live, if they're constantly worried about where am I going to sleep tonight, what is going to happen to my belongings, am I going to get beaten up in the middle of the night, those kinds of things, all the other efforts really don't matter. And we can try as hard as we want to support them in a number of different avenues to improve their lives, but if they don't have a stable, safe, secure place to live, it didn't matter. And so that's, I think, what initially motivated me to get into this field. And I think what has kept me here is every once in a while we're working with someone who's been, that have had a really challenging time in their lives. They've been traumatized as a youth. They have mental health issues. They're trying to manage things with substance use quite unsuccessfully. And they've been they're what we call street entrenched, but they've been living on the streets, sleeping in the rough for years, and to see them, the look on their face to walk with them while they experience the sensation of being housed, of finally having a roof over their head. It's not a bunk bed in a dorm where they're in a shelter, which is important, but it's the next step. To see that and to walk with them while they experience that peace and that sense of safety and security and I'm home is what keeps me doing this.
Well, it was the year 2000. I'm Kathie Chiu, by the way, and I was expecting my 5th child and had a 2-year-old still with me, and I was working in Maple Ridge. My husband and I had been appointed there as pastors, and there was a little lunch program that we offered every day for people, but there was no shelter. If you wanted shelter, you had to go to downtown Vancouver, and Maple Ridge is an hour away from Vancouver. And we all of a sudden started getting all these requests for shelter, and it just seemed like within this course of a year or so, there was this epidemic happening where there were tons of homeless people, there were shopping carts all over the streets, and we were getting several requests a day for shelter, and we didn't have one. And I thought, we need to do something about this. But, you know, I kept saying that, we should do something about this, we really need to do something about this. But the day that in walked this young woman who was the same many months pregnant as I was, and she had a 2-year-old in her stroller, and walked in and said, I'm homeless and I have nowhere to go. And she had left an abusive, she didn't qualify for transition housing, but she left a relationship that had gone really bad, and they had been living on a boat, and she was filthy. They're living on a boat on the Fraser River. And I'm the kind of person that sometimes takes people home with me when I shouldn't. But I had a house full of children and a son-in-law and a daughter who were married, and they had a baby. I didn't have one scrap of square inches for this person, but if I had, I think I would have taken her home. And I went home that night and I cried myself to sleep because I couldn't stand the thought that this young woman was out there and she had nowhere to go. And she slept in someone's car that night. And I vowed that I would find a way. I wasn't going to let that happen anymore. How could we live in Canada and that happen? It just floored me. So that's what we did, and that's how I really got involved. I mean, we've always dealt with people who have addictions and mental illness and who come for food hampers, and the Salvation Army traditionally serves people that are disenfranchised, but that blew me right off my feet.
Yeah, my name's Roger Butcher. Really what motivates me is having the ability to work with our nonprofit partners, whether they're running an emergency shelter, a transition, or subsidized housing. But what really sort of tugs at me every once in a while is we always get a nice note or we hear a wonderful story. As Brad mentioned, as somebody who's been homeless, has been using a shelter, has worked with the shelter operator to improve themselves, get connected to different services, and then being able to get into some type of housing, whether it's supportive or just independent housing in the private market. But when you hear those stories of those people who have faced multiple challenges in their life, whether it's from abuse in their family home, when they're growing up, or just because of financial circumstances that something happened to them during their lives, and to see them come back and become valuable members of the community, and also come back and support those organizations that supported them.
Thank you. Well, I think it's really important for us to keep in touch with that, the human level, and our experience with people that are homeless, and seeing the transition in their lives that housing people can make. Thank you. Charmaine, we tend to put housing and health in separate compartments, dealt with by separate ministries. I wonder if you could help us understand the link between housing and health, and why it's important for us to act on that understanding, both for individuals and for our community.
Great question, and I just want to start by saying if I oversimplify some comments, I'm sorry about that, because it's not a simple issue, but I have 6 minutes to say what I need to say, so I am happy to give more evidence and background information for people who want it, but for the statements that seem oversimplified, I apologize for that. So I just want to start by saying that housing is an absolute necessity for living a healthy life. It is a fundamental prerequisite to health. It's up there with food and water and air. And if we think about it differently, then we need to change our thinking, because it's key. Homelessness impacts everyone, the individual who's directly impacted in the community in which that person is from. So if we think it doesn't happen to us, it does happen to us. We're all involved with homelessness, and we're all impacted by it. Becoming homeless can happen to anyone. Many people are just a paycheck or two away from becoming homeless. And by homeless, I'm not necessarily only referring to absolute homelessness, but I'm also referring to what happens with insecure housing and people having to couch surf. And that population often becomes very invisible, and they are the majority of homeless. So we have to be aware that, not to make assumptions about people, and that it's not in this community, it's very much a part of this community, the homeless population. So if you're a youth, if you're a senior, if you're a child, if you're a family, you're all eligible for homelessness, and many of them can and do become homeless. Most people who experience homelessness have that happen for a short period of time in their life, but about 1 in 5 or 20% of the homeless population are chronically homeless. These people tend to be a little bit older. They've experienced long-term unemployment. They're more likely to suffer from disabilities. They have a long list of mental and physical health issues and oftentimes addiction. But they're not everybody who's homeless. But that chronic homeless population is a very important group of people for us to also understand, and how their health is impacted by their homelessness. So homelessness and insecure housing does directly affect people's health. Oftentimes these folks are undernourished. They don't get proper rest. When they get sick, it's very difficult to adhere to any type of treatment or medication regimes. And I mean, as physicians, it's ridiculous what we say to people: go home and rest, go home to bed, put your medicine in the fridge. You know, you have to stop and think about, what does that actually mean for somebody who's homeless? It can't be done. I remember during the pandemic influenza, we were telling people, if you're sick, stay home, to people who lived on the street. That doesn't work for people. Oftentimes, homeless people have to live or congregate in overcrowded settings. This increases the transmission of communicable diseases, for example, pneumonias or tuberculosis. And we did have an outbreak of TB in the Comox Valley not very many years ago. And invariably, it was the unstably housed that were affected by tuberculosis. So it is here, and it is, and it's happening to people right here in our own community. The frequent moves and instabilities threatens people's health. They're unable to maintain healthy social networks. They're vulnerable, highly vulnerable to much higher levels of physical and sexual violence. They are understandably at risk of despair, losing hope, self-esteem, and then you compound that with sleep deprivation, and it starts into this cycle of chronic depression and serious mental health issues. Trauma and injury rates are significantly higher, and specifically in regards to homeless populations, traumatic brain injury is way higher than in the general population. In regards to specific disease groups, being homeless increases your chance of having hepatitis C by 29 times, increases epilepsy by 20 times. You're 5 times more likely to develop heart disease, you're 4 times more likely to get cancer, and you're 3 times more likely to have asthma. So it's no surprise then that this population also has a significantly lower life expectancy and experience premature death at rates that we actually shouldn't tolerate. I just want to make special mention of the youth and how homelessness impacts on them. This is a group where the instability makes it extremely difficult or almost impossible for them to actually go to school and get an education. Then they can't get a job. And then how do they secure housing and food? And so these kids often develop or invariably develop physical health problems such as malnutrition and chronic diseases as kids that they carry forward throughout their life. Many will have to participate in survival sex just to survive, and this puts them obviously at risk for hepatitis B, HIV, and all the other sexually transmitted illnesses. Their mental health is profoundly affected, and all of this is occurring at the prime time of their life as they set the course for the rest of their lifetime. People who are homeless are hospitalized up to 5 times more often than the general population, and they're more likely to have a significantly longer stay, and they're also more likely to receive care from emergency departments. I have to just make mention of the justice system here, and that homeless are more likely to be arrested in jail. And in fact, a recent study showed that 1 in 5 Canadian prisoners was homeless at the time of incarceration. The flip side is that without proper adequate planning and support, people in prison are more likely to become homeless on release. So it keeps that cycle going. We're not thinking and planning about that. So as I said earlier, homelessness affects everyone. So if it doesn't affect you directly, it definitely will affect you indirectly as a community member, because homelessness is very expensive. It is a very expensive thing to maintain the status quo of people being homeless. So we have many Canadian studies that the evidence and the literature is out there that consistently show that the cost of providing emergency shelter, and I believe an emergency shelter is part of the continuum, but if we rely on emergency shelter, the cost of that service far outweighs what it would cost to provide rent to someone at market cost housing. It is significantly cheaper to provide rent and put them in a proper, affordable, safe home than to keep people homeless. And in fact, there was a recent study in BC, a very specific study, that showed that it is at minimum $20,000 a year cheaper to pay rent than to provide those emergency intermittent shelters per person, per year. So in our province, annually, we're spending hundreds of millions of dollars to keep people homeless. So those are just very brief painting the brush superficially over what it costs us, but that's not to lose sight of the human cost and the terrible toll that that homelessness takes on individuals and on communities. So this is, I don't think we have an option about ignoring this. This is something we really can't ignore. It's an inequity in our society that we should not be tolerating, and I believe that we have a moral and a social imperative to tackle this head on.
No, thank you, Charmaine. You've given us a lot to think about in a very short time. And I realize I'm asking you guys really big questions and only giving you a few minutes to answer. I'm going to move on to Roger. As we've heard from Charmaine, there's a wide spectrum of people facing housing challenges. Can you help us understand the range of housing needs and the continuum of housing options that's required to address them?
I mean, the housing continuum really is from emergency shelter all the way, hopefully, to affordable home ownership and everything in between. In 2006, our minister, the Honorable Rich Coleman, laid out the provincial strategy for this. There's 6 of them in Housing Matters. Homelessness has access to stable housing and integrated supports. And though emergency shelter isn't stable, a lot of people wouldn't qualify as stable housing. What it is, though, is a gateway into getting those supports that the people need, or being connected to those supports in the community, which helps them move along in their path. One of the other ones is most vulnerable citizens receive priority assistance, and that also includes women and children who are fleeing abuse, and working with the women's transition shelters and transition homes to support them. And also, BC Housing, what we've done is we have a supportive housing registry, very similar to what was talked about here earlier today. This is a one-stop shopping, working with Brad and the coalition. The coalition in Greater Victoria has what they call their CASH, which is their centralized access system to housing. So all the community partners have come together. So when there's a vacant unit, no matter who the person is, where the vacant unit is. If they're screened, the unit will be made available to them. So it cuts down a lot of bit of a bureaucratic shuffle. Another part of it is Aboriginal housing need is addressed. In 2006, CVHC and the federal government devolved their housing stock to the province of British Columbia. A good portion of that was off-reserve housing. BC Housing has partnered with the Aboriginal Management Housing Association, and just last year we celebrated the signing of an MOU. So now that housing designated for Aboriginal or First Nations people is now being run by an Aboriginal group. And we are, BC Housing is supporting them, but they have the autonomy to look at their housing, see where their needs and their gaps are, and try to develop more housing for their population. Low-income housings have improved access to affordable rental. If you look at BC Housing, we have about 7,000 units of what we call directly managed housing in the province. The nonprofit sector has 56,000 units. So we support the nonprofit sector in making those units available to people who are low income. The other part of that is the minister also announced the rental assistance program. So if you're a family or a single mother or a single father living in the private market, you're making less than $35,000 a year, you can apply to the rental assistance program, and you will, once you have qualified, you will receive a monthly subsidy from us, directly to them, not to their landlord. So they may be able to use that to pay a portion of their rent, pay their utility costs, or more importantly, is put some nutritious meals on the table for their children and child as they're growing up. We also are trying to support home ownership as an avenue of self-sufficiency. In Victoria, we have a program here that's a combination or a partnership between BC Housing, Burnside Gorge Community Association, Van City Credit Union, and a number of other partners, where participants can take part in the family self-sufficiency program. And what that really does for them is it helps them build gives them the education and the tools that they need to manage their finances. Part of that program is that they have a savings program. They have to start a savings account. And those funds are matched at the end once they graduate. And one story I'd like to tell you about is one of the young women when I first came over to Victoria in 2005, we went to graduation for family self-sufficiency. There was a young woman there who was living in one of our directly managed buildings, had a young child, took part in the family self-sufficiency program, got a job, happened to be with Van City, and at the end of the day, she had accumulated enough money where she and her father partnered together and they went out and bought their own home. So that's a really success story. We also have our shelter aid for seniors. And again, very much like the RAP program, if you're a senior, you're living in the private market, yet you need some help to pay your rent or pay your utilities or whatever, you can apply for SAFER and you can go on. Another thing we do is partner with our partners at Island Health in around the independent living BC, Casalola, just not far from here, run by Retirement Concept. There are 60 units in there that are subsidized through BC Housing and support services through the Vancouver Island Health. I need to change it. So those are some of the things that we do, but also as part of the continuum, and as I said earlier, in my job is working with the communities, like the Comox, Comox family, and trying to find ways that housing can be created for you. And that's a real important thing for me, because when I look at some of the housing developments that we've done recently, whether it's been in Victoria or Nanaimo or anywhere else on the island or in the Gulf Islands, really it's all about partnerships. I mean, We did a project in Victoria, it's 24 units of housing. It's for people working in the service industry. There was 8 partners that came together, from the United Way to my good friend out there, Henry Campoff from the Capital Regional Housing Trust Fund, to ourselves, to Home Depot, and even the private developer, to put these projects together. And as mentioned earlier here by one of the first speakers there, it is all about community and community coming together. I mean, as representing the provincial government, you know, we can only do so much. But when we partner with people, we can more than most often get something done to support that community.
Thanks so much, Roger. And as Roger's outlined, what the provincial government can bring to the table is really important in supporting what the non-profits are doing. And both you and Kathie are working on the ground with non-profits. And can you share with us, give us some understanding of some of the current practices and the outcomes for individuals and communities from work that you've been involved in?
Yeah, certainly, thank you. Where to start? It's difficult. One of the things I found challenging is even listening to Charmaine and Roger talking, oh yeah, well, we should talk about that. Well, let's make that. Okay, 6 minutes, Brad, take a deep breath. I think what I'd like to do, given that we're talking about homelessness, is to talk about a particular part of that continuum that Roger mentioned. So I think it's really important to point out that there is a continuum. Ideally, people would move through this continuum to whatever their highest level or their potential is. And emergency shelters, while we would love to not have the need for them, it's critical that they exist, as Roger pointed out, as an entryway into a system to be connected with support workers that people might not otherwise connect with. Transitional housing, all the way to, as Roger pointed out, to home ownership. There's a spot in the middle that I'd like to speak more specifically to, and that's around supported housing. And supported housing really, quite simply, is about housing with supports. So it can take many different manifestations, and it looks very different depending on who's delivering it. I think the healthier the community is, the more variety of this kind of thing you have. Supported housing essentially for people that have significant barriers to stable housing, that are likely, as Charmaine spoke to earlier, experiencing some mental health issues, trauma in their lives, substance use issues, brain injury, fetal alcohol effect. There's a whole spectrum of barriers that are going to make it really challenging for someone to maintain housing independently. So what's provided through nonprofit agencies, through Island Health, support through BC Housing, is affordable housing. So that's one of the key pieces of it. And some kind of staff component, professional supports that may look like a broad spectrum of things, from psychiatrists and psychiatric nurses and occupational therapists and doctors, to community support workers and social workers. Providing supports and looking at what is specifically what is needed by whatever population that supported housing is designed to serve. They could be specific sites, so a building, Pacifica runs 4 buildings that are purpose-built or converted motels that are designed specifically to support people with these kinds of barriers and have staff on site to do that. Some models are what they call scattered housing, so the program that I'm running right now is Streets to Homes, works with private market landlords and supports people in existing housing in the community with help and subsidies through BC Housing. So it's a very wide range of types of supported housing. And again, it dictated by the philosophy of the agency providing the supported housing. Island Health traditionally has supported housing buildings or resources that have a high degree of clinical kinds of supports, which are imperative for a community to be successful. I think you need to be able to support people that have profound and significant mental health issues to remain stably housed. That goes all the way to the other end of the spectrum, which I'll speak to in a little more detail, which are philosophies like harm reduction and housing first models. I'm probably not going to do any of these really justice in 6 minutes, as Charmaine said too. Pardon me for being perhaps overly simplistic with some of these concepts, but I'm going to be around afterwards if you'd like to talk to me, or I'm sure a number of other people in the room that have knowledge of some of these specific types of support models. Feel free to ask. So the goal of supported housing really is to maintain stability in your housing and to be supported to whatever potential you have and that person might have to achieve whatever it is that they're able to achieve with the supports that they have. Let's see if I missed anything here. I think that's, in essence, that's what the supported housing is about, is really maintaining the stability of the housing and supporting people to their highest potential. I want to speak a little more depth about housing first. It's a fairly recent innovation in terms of helping communities cope with issues around homelessness. It, in my mind, works in conjunction with or is complementary to a lot of existing services like emergency shelters, like more clinical models and more comprehensive models of supported housing. Housing First essentially is based on a couple of, based on 5 kind of premises. The first is that there's an immediate access to permanent housing. So the theory basically goes that if someone is homeless, unless you get a roof over their head and get them housed, all the other things you try and do to help support them aren't going to have much of an effect. And some of the housing that exists, there's some that's abstinence-based, so you can't be actively using substances if you want to live there. Some it's based on particular programming. You have to meet with your case manager daily. You have to be coming to mealtime at a specific time. There's parameters around that, and that works really well for a certain portion of the population. It's actually critical for them and their success. For others, not so much. And so it's talked about with the phrase low barrier, but Housing First essentially is based on the fact that regardless of what choices you're making right now, we're going to find you housing, we're going to give you a subsidy to support you in that housing, and then provide some supports. So the first piece really is without any barriers, without any prerequisites, you are housed. The second piece is that it's a client-centered program, so that there's some choice there. In the program that I run, we were working with a number of different private market landlords, and so there's some opportunities coming up at the beginning of the month. There's maybe 2 or 3 different units available. We take the client around and show them the different units, so they have some kind of say in what's going on in terms of where they live, what that looks like. So consumer choice, I think, is a big piece of that. And also, in terms of client-centeredness, is what is it that they want to work on? What does support mean to them? And what supports are tailored to them. For some people, it works really well. Others, not so much. But I think for a certain portion of this population, again, providing them with the opportunity to say, well, I really want to, want a new pair of shoes. That's my focus today. The fact that they're actively using crack cocaine is not on the table right now because it's not something that they've identified as wanting to deal with. Over time, when you establish a relationship with them, the opportunity to start to address that comes to the fore. But right now, they want a pair of shoes, so you're working with them to get them a pair of shoes. Another piece, another one of the foundational principles of Housing First is that it's recovery oriented. so that the goal is always to help that person rise to, again, their highest potential, their capacity, wherever that lies, in a way that their life is essentially, I don't like to use the word better, but they experience their life as being healthier, they're more content, they're more at peace. So I'm moving through these really quickly here. I spoke already about individualized client-driven supports, really looking at what it is that they want to work on, what they need, and working from there. Once the relationship is built, helping them understand the repercussions of other things that they're doing that they may not have identified that they want to work on. Once you've built trust and the support worker has been working with them for a while and has developed rapport with them, and they have a concern, say, that maybe they keep losing things that are really valuable to them. Well, you notice that tends to happen whenever you're using a lot. And so helping them become more cognizant of the impacts of the lifestyle choices that they're making, and then providing them with some viable alternatives and some alternate choices as to ways that they can improve or change what they're doing. The final piece, I think, which is really a key piece of the Housing First model and others as well, is social integration. Particularly where you have a scattered model, where you have people living in existing private market apartment buildings and units, is that there's the opportunity there for integration. People start to experience living like everyone else does, like the normal people do. And it has a huge impact on people's self-esteem and their capacity to start to make other choices that because they see themselves as being included, as being valuable, as being a part of this society as opposed to someone living on the fringe. So not only where they live, but how they're integrated. So supporting people in getting a pass to the community center, to be taking classes or going for a swim once a week, to becoming involved in community, other community activities, events, volunteering. Those kinds of things are all critical, I think, in terms of helping them, again, rise to their potential. I also just wanted to briefly tag on something that Charmaine pointed out, Roger too, around costs. It is really expensive to keep someone homeless. And relatively speaking, given how often they access emergency services, which are very expensive, time they spend in emergency wards, police time, those kinds of things, to take a portion of that money and actually provide them with a rent subsidy each month. The Streets to Homes program that we're running in Victoria, it costs roughly $7,000 a year to provide someone with a subsidy of up to $3,000. So each person, $7,000, their subsidy of up to $300 a month. A support worker providing them with everything from assistance with budgeting, meal preparation, to getting to their doctors, to finding appointments with psychiatrists, to reattaching with family members, etc. For $7,000 a year, these people are stably housed. And that's huge when you look at, I mean, it's significant, really, when you look at how much it costs to keep someone homeless. I'm just stopping because I think I'm working on 6 minutes.
Thanks so much, Brian. We've got enough time for you, so we're going to have to cut in a little bit on the questions, but I think what everybody's saying is so valuable. I hope people don't mind us kind of squeezing down the question time at the end. So I saw you nodding a lot when Brad was speaking, and you talked earlier about what inspired you to get involved in working in homelessness. You've had a lot of experience since then. What can you do to help us understand about systems for addressing homelessness and the benefits that they produce for individuals in the community?
Well, I think where I'm at right now is a very old model of how to deal with homelessness. There's a 21-bed shelter. There's a 43-bed halfway house on the top floor, and then the rest is transitional housing, which really hasn't got any programming to go with it right now, except we do have some addictions programming. So I'm really thrilled that I'm there because it means I get to transform something. So I like to do that. But if I speak more to my experience in Maple Ridge, it might be a little bit more to where you're at now, because Maple Ridge is a smaller community, a very tight community that works together. I want to talk to you a little bit about shelter, because we talk about Housing First a lot. And Housing First is a very important program, and I think what you touched on was that it's a very good program for a good part of the population who are homeless, but there's a section of the population of those who are homeless who would be in Housing First, and then the landlord would evict them, no matter how many supports you put in place. So there's things that are problematic, but I want to tell you why they're problematic. And that is because shelters are like the triage. How many of you have gone to the emergency department? And it's not a first come, first served, is it? It's, you go to the triage nurse, and she sorts you out. And she figures that you need immediate care because your heart's going wonky, and you just cut your fingers so you can wait until we take care of her heart. And shelter's kind of like that. People come in the door, and they come in with all kinds of stuff. Majority of them have been through the foster care system. That's one aspect of the people who are homeless. A lot of them have ADHD, learning disabilities, all kinds of different things. A lot of them are very creative and talented people. They're artistic. A lot of them write poetry, do music. I used to loan my guitar all the time to Tattoo Ray, we used to call him, and he's the only one I would let take my guitar out and play it because I knew he wouldn't steal it. But he lived in the bush, and it took us years to talk him into coming in. So there's all kinds of different characters out there. But the interesting thing is that they're just like you and me. They're characters. They each have their unique personality. And so I really like what you were talking about too, is that client-centered approach, because each person that comes to us has a different issue. I think part of the favorite part of how we did shelter in Maple Ridge was I liked the cold, wet weather season. We used to get some extra funding to have extra mats in our downstairs area, but our shelter upstairs, they were individual rooms in a dormitory. So you'd have a long hallway with separate rooms. So everybody, each of the men and the women in their own separate place, had their own bedroom. And they had a communal lounge and a kitchen where they could prepare food. And they were encouraged to do their breakfast and their lunches together, and sometimes their suppers. And they could take part in the community dining room that we had if they so wanted. But they were encouraged to do some things together, and we had caseworkers and life skills coordinators working with them. But the thing I liked about the cold weather season is because these were the chronic homeless. They were living in the bush by the Fraser River. And so they would come in because it would be really wet and soggy, and we would get to know them. And over a 5-month period, you can really get to know someone. And it was at the end of that 5-month period in March when we'd start saying to them, because now I know you, right? So you and I now have a relationship, and you talk to me about your life, and you trust me because you know I'm not going to blab with someone else, and I've said some good things to you. So now we're talking, and I'm saying, what are you going to do now? Cold weather's over. What are you going to do with your life? What's your purpose? And that's when we can start to make a difference. And we had a transitional housing program, and then that was for people who really wanted to get clean. It would be people with mental health issues, addictions issues, and sometimes both. And we never knew what came first, the chicken or the egg, you know. But there was one girl that called me up one time, and she was really interesting. Her name was Lori Mead, and she had schizophrenia. We're not sure if it was drug-induced, but we know she used. And she was chronically homeless, and a lovely young girl from the community of Maple Ridge. Everybody in town knew who she was. And she used to call us up and say, I'm coming home now. and it was kind of funny, and we'd laugh about it, but I'd think to myself, gosh, she calls a shelter home. So although we know shelter is a really important part of it, it can't be used as a long-term solution. It has to be used as a leaping board, as a springboard into another type of housing. What we do is really important. It needs to continue to be supported by every community. Every community needs to support their shelter and needs to support it well, because if it's done well, then you can make a difference in a person's life and springboard them into programs like Housing First and transitional housing. Right now, we're reimagining what we're doing at the Addictions and Rehabilitation Center. We call it the ARC. And we're looking at new models because we have to have a building retrofit. It's going to cost a lot of money. But we're thinking, what a great time to reimagine the programs we're running and do them differently, to get people prepared to go into the Housing First models, to go into rehab or come back out of rehab. So shelter, bottom line, it's probably one of the most important aspects of the housing continuum because you need a triage department. But it's not a long-term solution, but it won't go away. The one thing that's really impossible about shelters though, and I just want to say two things about that, is that once someone comes through and we've identified their issue and we kind of know where they need to go, we know they need to go to rehab and we convince them to go to rehab and they go to rehab and they come out and we've got nowhere for them to live and they're homeless again. That's really frustrating. Encouraging your communities, your municipalities to say to the person who wants to build luxury condos, yes, you can have a permit to build luxury condos, but 10% of your units have to be affordable. Any kind of thing you can do in your community to promote affordable housing, because once we're done with them in the shelter, we need to be done with them. We don't want to see them again if we don't have to. And so it's really reprehensible for us as a community to make sure that we provide affordable housing. The other thing that's an issue is that we hear a lot of talk about Housing First, and I think Housing First is a good issue. But I know of a place in Ontario, I worked in Ontario and London for a year in a big institutionalized setting with shelter and transitional housing. And the local government in that city has decided to decrease funding to shelters because we're going with Housing First. Except that there's no more affordable housing. They haven't created any units of housing. And so now the caseworkers have been laid off and the advocates have been laid off and they've had to decrease the number of beds. So as a community, and I say this to Comox Valley, you have to do this well. You have to get it right. You have to have shelter, you have to have transitional housing, and you have to have more units of affordable housing. And the three go together. And you can't have them apart from each other, because it's a continuum.
So I'd really like to thank you all for squeezing so much information into such a short time, and it's very difficult for you to do that. Is it all right if we just go 5 minutes over? I just want to see if there are any key questions people have, burning questions before we go to lunch.
I was just wondering if you could take a minute to define affordable housing, because in my limited time at looking at this, it has many different definitions depending on who's considering it.
And I would agree with you. Affordable housing is defined through CVHTF, the federal government, is you shouldn't be paying any more than 30% of your income for your house, right? That's whether you're home ownership or whether you're renting. So that's the definition that we usually use across the board, is the rule of 30, no more than 30% of your income towards your housing. So that's how we define affordable housing. And there may be other models, and as you said, rightly so, you know, I'm sure there's probably 4 or 5 different explanations or thoughts around what affordable housing is to the number of people here in this room.
I don't think I touched that. Yeah, I mean, where I would go with that would be, I'd be more inclined to talk about, I'd be more inclined to talk about quality of life. Quality of life varies dramatically. Depending on who you're talking to, what their expectations are, what they have, all those things. So it's a moving target, and I think that it's more about, in my opinion anyway, about increasing quality of life and having people have the capacity to make choices about where they put their money and where they put their resources. rather than saying, well, because you're on income assistance or person with disabilities, that you have this much for shelter or this much for everything else.
We had a question over here.
I have a comment, actually 2 comments. One regarding the SAFER program. The SAFER program does not keep up with the cost of living, and it should be attached to the cost of living. Also, needs to look at the housing market and what the average rental properties go for, because CMHC needs to reevaluate this 30% of their income, because if you're earning approximately $10 an hour for 160 hours a month, that's $1,600. There's no way people are paying 30% of their income. Some of them are paying 70%. And this is why it's, housing is unsafe. So CMHC needs to look into that. Also, Canada has no public housing, really. We've really fallen behind on this issue. British Columbia is, I would say, at the bottom of providing public housing. And you're talking about partnerships and things like that, but I thought the charter guaranteed housing as a right in this country. And I'm fed up putting people up in my shed with no running water because they can't find a place to live. Thank you.
Yeah, well, I think you're right. One of the difficult things, and this is what we heard a lot when we were in Maple Ridge, was, well, if we build affordable housing units, it'll become a slum. And in a sense, that's right too, because if you lump all of the low-income people and people with needs that need supports in just one spot, then yes, that's what can happen. And what really needs to happen is communities need to plan their housing out. Before we became officers, we lived in a community outside of Toronto called Meadowvale, and it was the only planned community in Meadowvale, and they actually allotted land for, this land will only be townhouses, these lands will be apartment buildings, these ones will be, and this will be a park, and this can be a church. And they had it all planned out before anything was built. It was kind of really interesting. But there was room for everything in it. Every little community where you lived, you came across a little park. But the one thing that they forgot about was affordable housing for people, and they didn't have that. So they built a great big subsidized housing unit, and it quickly became a scary place to go. So I get communities have those issues, but you don't have to build them all in one place. And you can build them, when you're building a subdivision, you can have a part of it be, a percentage of it be low income for people with low income, and subsidize it. So, but there is ways to do it, but you just have to have a concerted effort to do it. And we're fortunate in BC that we have one government agency that oversees this. I think so, because in Ontario, the provincial government doesn't mandate. They give the money to the cities, and then municipalities decide what they want to do.
Yeah, I'm homeless right now, and there's 100,000 senior citizens in this province who have to access food banks. I've listened to politicians and their rhetoric for years here, and they have great ideas, but nothing is implemented. My question is this: when are you going to implement some of these good ideas I hear here today? Because they're needed, and they're needed now, not tomorrow, not next year. They're needed now. And things that I've seen get worse over the years, and that maybe if you had to spend a night out in the cold in a tent, you might move it a little faster, So I'm just tired of the rhetoric, and I think it's time for action. That's all I can say. Thank you very much.
I think that's a good message for us to end on. Thanks for sharing that. Has anybody got any burning questions? Because we're getting into lunch time.
Actually, we do have to call this panel to an end because there's a workshop lunch for the elected officials and the agencies. So I want to thank you all very much for your time and sharing your expertise, and continue the dialogue through the day.